Tanya here?
Yes, I'm here.
Okay, hi, how are you?
Hey, good. How are
Okay,
you?
let's get it started. It's 7:04. All right, well, good evening. My name is Bob Akivi. It is a semi-clear day here in New York City. It's 7:05 Eastern Standard Daylight Saving Time. Tonight, we have the pleasure of having a joint session with endocrine section discussing parathyroid disease. Those of you who might know that head and neck surgeons don't do as much parathyroid, I think we are the best people to do it because we know the anatomy the best. We can improve our footprint. So that's why we selected this session. Tanya has been kind enough to accept the responsibility and arrange the cases and the presenters and moderators. So without further ado, let's start. Tanya, let's go ahead.
All right, so thank you to everybody from the endocrine section. We have 3 guest faculty that have agreed to come together for this parathyroid disease virtual tumor board. Our first case will be presented by Dr. Jeff Mella from the University of Virginia, and discussing that case will be Dr. David Shanka, also from the University of Virginia. So Jeff, if you'd like to go ahead and get started, we can share the screen with you.
Okay, let's go ahead. So
Thanks,
just remind everybody that every case is all about 20 minutes. During the case, we would ask the guest and our expert for input. Let's hear it.
All right,
Okay.
sounds good.
I'm going to share my screen here. Sorry. Okay, are you all able to see that?
Mm-hmm.
Perfect. Well, pleasure to be here and be able to participate in tonight's webinar. Thank you for having me. My name is Jeff Mella. I'm a current second-year resident here at the University of Virginia. And a quick thank you to Dr. Shanka for allowing me to present one of his patients. Our hope is that our case presentation will illustrate the classic workup of hyperparathyroidism. So a 60-year-old female was referred to Dr. Shanka with the chief complaint of fatigue, bone pain, myalgias, constipation, sleep disturbance. She had a normal exam with no palpable masses in her neck and a normal laryngoscopy. She had a calcium level previously drawn that she brought with her at 11.6.
Okay, so let's just stop here.
Are there...
David, what's your routine when you see patients like this?
Yeah, good. So I think Jeff points out some important things. One is, getting a very detailed history from the patient. Obviously, a lot of times they'll have a number of complaints. Occasionally they can be, somewhat vague. So obviously some of the symptoms that come with hyperparathyroidism could be attributable to other causes. I think we all sort of recognize that kidney stones are, something that you can really put a finger on and is very classic. But, a lot of patients will tell us they have fatigue, that they feel foggy all the time, maybe some depression, frequent urination, particularly waking up to urinate at night, bone pain, constipation, abdominal pain. And she had quite a few of those symptoms. And so I think it's important to kind of nail down all those things and get a sense for, what may be related to the hypercalcemia. It's really important to do a good physical exam, and particularly a good thyroid exam to make sure there aren't any palpable masses in the central neck. If you feel a mass, you either are worried about concurrent thyroid pathology or, potentially a parathyroid carcinoma. A normal parathyroid adenoma should not be palpable, and so that's an important thing to look for.
Okay.
And then,
so in the interest of time, David,
yeah.
We have 3 cases.
Sure.
When the patient comes, the usual scenario is somebody sees a high calcium and they send them to you. What are the tests that you order?
Right. So yeah, we'll get to that on the next slide. But
okay,
for me, it's calcium level at the same time as a parathyroid hormone level, and then you can see the other tests that we checked on our patient here.
So, question for you: do you routinely get vitamin D levels?
I do. Obviously the vitamin D level can affect the parathyroid hormone level and the calcium level. So, particularly as you look at patients with the low biochemical profile types of hyperparathyroidism, either normohormonal hyperparathyroidism or normocalcemic hyperparathyroidism. You want to differentiate particularly normocalcemic hyperparathyroidism from other causes of hyperparathyroidism like vitamin D deficiency. And so a low vitamin D level with an elevated PTH and a low or even low normal calcium, and then you're thinking that this may be vitamin D deficiency causing the elevated PTH rather than primary hyperparathyroidism.
So that was the first point I wanted to make sure that everybody knows, that nowadays, especially with this epidemic of vitamin D deficiency, it's very important for everybody to have vitamin D. And I see that you got the 25 vitamin D. So you routinely do D2 or D3?
So we routinely do a 25 hydroxy vitamin D, which is the inactive form of vitamin D. If you're concerned about sarcoidosis or other granulomatous disorders, then the 125 dihydroxy vitamin D is a crucial test to look for extrarenal activation of vitamin D that might be causing hypercalcemia.
Excellent. All right, let's go ahead.
The patient also had these other tests. 24-hour urine calcium was obtained, which was 167 with a normal range and a little bit over 1,200 cc's of volume over that time period. She also had a DEXA scan, which showed no concern for osteopenia or osteoporosis.
Yeah, I think the 24-hour urine calcium is crucial. Of course, what you're ruling out with that is familial hypocalciuric hypercalcemia. And that can have significant overlap with hyperparathyroidism in that these patients can have a slightly elevated calcium and a slightly elevated parathyroid hormone level due to some insensitivity to the calcium sensing receptors.
However,
I would like everybody to mute their microphone if they're not talking. Okay, great. So
you listening to something, I take it?
Excuse me? Okay, let me ask a couple of other folks. I see Brandon's active on the chat box. Brandon, do you routinely get the 24-hour urine?
Thank you, Babak, and congratulations on this great program. I must confess publicly that I do not get a 24-hour urine collection on everybody. Correct. If it walks like a duck and quacks like a duck, I'm pretty good with going with the calcium and PTH, as David had mentioned, very important, done at the same time.
And do you use a nomogram for vitamin D, corrected PTH that it came out a few years ago, that you put it in the formula and to see if the PTH is appropriate or not?
I've occasionally used the nomogram, but I wouldn't say that, honestly, that I use it in everyday practice. But if there's any deviation, certainly if this looks like a borderline case, because you have over 40% prevalence of vitamin D deficiency, and many of these people have really a mixture of primary hyperparathyroidism and some vitamin D secondary hyperparathyroidism, I think it's real important to check the vitamin D. But to your point, I don't get a 24-hour urine on everybody.
Yeah. Okay, good. I'm glad I'm not the only one in the wilderness. I same as you, I don't routinely do. And if I have any question, I usually ask my endocrinologist to weigh. Okay, go ahead, Jeff.
Okay. The patient also had some outside imaging done prior to our evaluation. So on a SPECT CT, there was no evidence of a parathyroid adenoma. And on a thyroid ultrasound, it showed a sub-centimeter hypocoag nodule within the left thyroid, which was low suspicion under ATA criteria and did not meet criteria for biopsy, and then did not identify any abnormal parathyroid glands.
So let me ask David.
No abnormal parathyroid glands were visualized.
Yeah. David, if a patient comes to you and you do the lab test and it's hyperpara, what is your routine imaging? What do you get for everybody?
Yeah, so I think the couple things I wanted to point out. One is, well, quickly back to the 24-hour urine calcium. I do think one of the other helpful things about getting that is that you can stratify the severity of disease. So certainly in patients that maybe are asymptomatic, if you have a 24-hour urine calcium over 400, you'd sort of push them more towards surgery. So that can be helpful too.
Sure.
But in a patient, where you've got the diagnosis and they have a surgical indication, as this patient does with a calcium 1 milligram per deciliter above the upper limit of normal, I remind our residents all the time that imaging studies are for surgical guidance. They're not diagnostic. And so the diagnosis is biochemical. The imaging is for helping you out at the time of surgery. And so what I would say is if I could only get one imaging test, I would get an ultrasound. And the reason for that is that one, you can find parathyroid glands well with that, particularly surgeon-performed ultrasound. There are studies that show that if you do your own ultrasounds, that's actually advantageous over a radiology-performed ultrasound. So I'd encourage everybody that's interested in doing this as a career to learn to do ultrasound yourself. So not only can you find parathyroid glands, but you can also identify concurrent thyroid pathology. And of course, you would not want to operate on a parathyroid problem and miss something going on with the thyroid that you should have dealt with at the time.
So let me ask you this: do you routinely get an ultrasound? What about a SPECT?
So I don't routinely get a SPECT. I've found, at least in our practice at UVA, that 4D CT has been superior to SPECT CT.
Do you get both ultrasound and 4D CT?
I usually do. I've found that the 4D CT will help to find small superior adenomas that are really difficult to visualize on ultrasound. So I think that the combination of studies are actually complementary.
Sure. So one of the things we're trying to do in this program, just to show the fellows that there are many ways to skin the cat, and not one way or the other is better. And as David mentioned, it all depends on your specific practice. So let's ask a couple other folks. Brandon, what kind of imaging you do routinely?
Ultrasound and 4D CT, and I hope that I have co-localized on those two scans, and I feel very confident that I'm going to be successful.
Okay, Jeff Luke, and you on you. What would you do?
You know, I find some of these cases to be the most challenging. Nothing is more frustrating than getting to the operating room and not finding what you expect. So I kind of try to maximize my preoperative workup. So honestly, I usually get to ultrasound and 4D CT and Sestamibi, because I want to see all the data point in the same direction, because I feel like when I get to the operating room and it's not what you expect it to be, you're like, oh, I should have gotten that test. So I usually do all three. There's probably more cost than it should be associated with it, but I usually get all three. At least the ultrasound and the Sestamibi. The 4D CT is, I think there's a lot of technical issues with your institution for success.
You know, I think one thing to consider, though, is when you get ultrasound and CT, those are both anatomically based studies. And so it's important just to recognize kind of how these tests work. So Sestamibi scan is based off the function of the parathyroid, assuming adenoma, right? So I just would encourage people to think about, when you get these tests, kind of how they work, right? So ultrasound and CAT scan are anatomic studies. Sestamibi is functional. And at least in my practice, I find that using ultrasound often with Sestamibi, you're getting complementary approaches to the same type of disease as opposed to duplicating the same type of study.
So Babak, can I make a quick comment to Michael?
Very quick.
Michael is absolutely correct. And so what I do is I do the ultrasound, the 4D CT, and then I give a dose of Sestamibi on the morning of surgery, and I use that with the gamma probe. So I think that's the perfect combination of function and anatomy.
Perfect. All right, let's go ahead, Jeff.
Okay. The day of surgery, we performed a perioperative ultrasound. So this is a surgeon-performed ultrasound. Here we have the trachea, the thyroid isthmus, and the left thyroid lobe. And then we see this 1 centimeter hypoechoic lesion just underneath the thyroid capsule. And on power flow Doppler, there was evidence of axial blood flow. Here,
yeah, so I asked Jeff to put in, well, first of all, this is really classic for a parathyroid gland on the ultrasound images. You can see they're typically hypoechoic, they're uniform, usually with a very smooth edge to them. And if you use that power flow Doppler feature, you can often find a single blood vessel coursing into the adenoma. So that's a really classic finding for a parathyroid gland. And it's, another pitch for surgeon performed ultrasound here, because this was the thyroid nodule that was just sort of called a mostly cystic thyroid nodule that didn't meet biopsy criteria on the the formal radiology interpretation at the outside hospital.
Yeah.
And so, of course, if you do your own and you're used to anatomy, you will know better to catch that.
That's an excellent point. Okay, we are almost running out of time for the first case. Jeff, want to finish this?
I asked Jeff to throw this up just quickly so that this is not this patient's 4D CT scan, but this kind of shows the way a 4D CT works for those of you that aren't familiar with it. So on the, it's really a bit of a misnomer. You kind of get a non-contrast scan and then an arterial phase contrast scan. So above you see the non-contrast scan, and you can see there's a thyroid tubercle on the left, and that has the same characteristics as the thyroid. It's on both the non-con and the contrast enhanced, whereas in the right superior location, you can see on the non-contrast, you've got a lesion that's hypoattenuated relative to the thyroid, but then on contrast, it avidly enhances. And so that's a superior parathyroid gland. So now Jeff will show you what we found on this particular patient.
So here's this patient's 4D CT. Here we see kind of a cookie cutter lesion here in the left thyroid lobe, again, hypoattenuated compared to the thyroid, whereas over here on the post-contrasted scan, it is hyper-attenuated compared to the thyroid.
Perfect.
Here's what we found day of surgery. Superior to the screen, left thyroid lobe with the strap musculature retracted laterally. And we see a discoloration. It's saying your internet connection's unstable. Can you all still see me?
Yeah.
Yeah.
Okay, good. A little bit of discoloration just underneath the thyroid capsule here, better appreciated on this photo here. But again, left thyroid lobe, and you just see essentially the border that would be an otherwise easy thing to miss had we not gotten localizing scans prior.
I see a very bloodless field. Nice job, David.
Oh, thanks. I hate blood.
Okay.
And again, we see as we dissected it free of the left thyroid lobe, trying to spare the thyroid lobe, the hypoechoic lesion came out very consistent looking with a parathyroid adenoma. Weighed 190 grams.
You said the baseline and the T0 and then T5. Now, let me ask you, what's your routine? Do you do, when you take it out, do you do a T0, T5, T10, or you just do T0 and T5?
I do a T0, T5, T10, actually T15 often, as we're kind of closing if I'm really, happy with it. And the reason I do the T0, and this actually just benefited me last week. So occasionally that'll bump quite a bit. So I actually had a patient last week that started with a baseline of 61, and at T0, the PTH had increased to 120. And so then at T5, it had come down to 60, which would have made me pretty nervous if I didn't have that T0, and then it continued to drop after that. So you want to see that continued decrease. And I really like to see the last value to be, less than 50% of the baseline, and ideally under 40 would makes me feel a little bit better. If it's still above that, I get a little worried that there might be something else going on.
Great. Yeah, I guess a lot of us would do at least have to be 50% and within normal range for your lab. Okay, so, and I can see 6 months post-op, everything looks good. Any last slide, Jeff? You guys will move on to the next case.
This is it.
All right, fantastic. Excellent case, excellent, and really excellent presentation, Jeff. I hope you consider doing head and neck.
Absolutely, thank you.
Years to come. Okay, Tanya, who's next?
So next we have Dr. Brendan Stack, and presenting that case will be Dr. Betty Chen from Southern Illinois University School of Medicine.
Excellent. If you
I'd like to add something real quick, Babak, if it's okay, just something for the fellows about the last case. So, oftentimes we get these scans from outside facilities. I think it's really important to try to look at those scans yourself, even if they're terrible. Sometimes the radiologists don't always pick it up, or they're not looking. I think with us being trained the way we are, we often pick up lesions, even on a 4D CT, that some radiologists, if they're not head and neck trained, they're not going to see it. So I would say don't rely on a report. Always look at scans yourself. Sometimes you'll find the need that you don't even need to repeat it, and you have the information you need.
Yes. So Brandon, can you put your presentation up? Okay, Ben. Okay.
Eddie's going to do that. Okay.
Perfect.
Can everybody see my screen?
Yeah.
Yeah, Betty, can you put it in presentation mode? There you go.
Perfect. I think you have to change your screens, but that's okay. We can go ahead in the interest of time.
Okay. Sorry. Sorry, for the sake of time, I think I'm just going to go ahead and...
Yeah.
So, good evening, everyone. My name is Betty Chen. I'm one of the PGY4s at Southern Illinois University, and I'd like to thank Dr. Stack and the American Head and Neck Society for the opportunity to present this case. So, here we have a case that was performed by one of our head and neck surgeons, Dr. Arun Sharma. This is a 72-year-old female with a history of hypercalcemia for 3 years and a diagnosis of primary hyperparathyroidism. She has no other symptoms, no personal history of renal disease, and no family history of hypercalcemia or hyperparathyroidism. She did have a serial DEXA scan that showed progressive osteopenia. And so on pre-visit lab panel, she had a hypercalcemia of 11.5, which is 1 unit above our upper limit at our institution of 10.4, PTH of 231, and vitamin D of 27. Her 24-hour urinary calcium level was significantly elevated at 443, and her creatinine and GFR showed a relatively normal renal function.
Okay.
So on preoperative imaging, she had the ultrasound scan performed by radiology colleagues that showed a 1.7 centimeter hyperechoic nodule superior to the right thyroid hole, but there was no radiologic evidence of a parathyroid adenoma. On additional imaging evaluation of this nodule, we had a CT contrasted neck that showed an appearance of the nodule consistent with a lipoma, which I indicated with the arrow there. Again, no candidate parathyroid adenoma was identified on this imaging. Similarly, on system movie scan, the patient had no evidence of any parathyroid adenomas.
So you have a negative system EV scan.
Correct.
But biochemically, it obviously looks like a picture for that. So let's see, Michael Singer, what would you do?
I would bring the patient to the operating room and do a bilateral exploration.
Okay, any other comments?
I think that is the correct answer, and Michael always gives the correct answer. I would just say for the audience that perhaps there would be some other imaging modalities, but this is getting into the fringe of non-approved imaging or experimental things, but just so that people are aware, there would be some other possible imaging that could be deployed.
Yeah.
So just one additional comment that I'll make. So I see this, and I say this not proudly as a surgeon. So I see patients who come to see me all the time, who've seen other surgeons in the past, some several years before, who've been told, oh, there's no positive imaging, so you're not a good candidate for surgery. And to me, that's a completely inappropriate thing to say as a surgeon. It's one thing to say you're not a great candidate, in terms of my experience, in terms of my practice, but let me refer you to someone who does this on a more, say, regular basis. As David said before, I think this is really important. The diagnosis and the decision to proceed with surgery should not have anything to do with the imaging. That doesn't mean that you need to do it if it's non-localizing, you don't feel comfortable, but then refer the patient on.
All right, sounds good. Let's ask our resident skeptic, Dr. Don Veed. Don, what would you do if the system EV is absolutely negative?
Hey, I would explore the patient. I mean,
Okay.
at this point, that just makes the most sense to me.
Yeah, okay. Anybody would not do that. If
Well,
anybody wants to make a comment that they would be a little bit, you get more tests before exploring. I think exploring is very reasonable, at least in
I
my
would
opinion.
add that one thing you can do that occasionally is helpful is what I'll do sometimes with these totally non-localizing ones, and I agree, like look at your own scans, review it over and over again. Sometimes you'll find something the radiologist missed, do your own ultrasound. But then if you're still in that position, I have occasionally under ultrasound guidance, right as the patient sort of gets into the room and is asleep, sampled the IJ on both sides, kind of down low. And drawn some blood from those locations, like level 4 on both sides, and occasionally you'll get a hit on that, and you'll see a significant difference. I just had one about 2 weeks ago that on the right side the IJ in level 4 was like over 200, and on the left side it was peripheral levels, same as what we had gotten in the holding area. And so we did our approach on the right side, and sure enough, right away found a beefy inferior adenoma that somehow just didn't show up on any imaging studies.
Perfect.
So
that's
Dave,
a great trick.
Dave, you're sort of stealing our punchline.
Oh, sorry.
No. If Betty goes ahead, you're sort of stealing the punchline. Not exactly, but sort of.
Oh, thank you. All right. So we did what the majority recommended and sign up the patient for surgery and possible bilateral exploration. So during her preoperative or perioperative ultrasound, we had a surgeon performed ultrasound as well that actually did show evidence of an ovoid hypoechoic nodule posterior to the left thyroid that appeared suspicious for an adenoma. And so intraoperatively started exploration on the left side, and intraoperatively did find an enlarged left superior parathyroid weighing at over 800 milligrams. And the PTH level decreased significantly from 306 preoperatively to 28 as evidence for an enlarged parathyroid gland. And this was confirmed on our final pathologic specimen that showed an enlarged hypercellular parathyroid. The patient, 8 months later, had resolution of her hypercalcemia and hyperparathyroidism. And I didn't show a vitamin D, but it was also normal as well.
Okay, great. Now, what's your last slide?
Yeah, my last slide is summarizing what many have already talked about in terms of management and imaging modalities often used in primary hyperparathyroidism. And as we talked about, ultrasound is typically the first line, as it is the most cost-effective, most patient well-tolerated, and easy to do. And it's usually done on our institution as well. Cystomebi is one of the most common functional studies that we typically employ at our institution. We talked about Sept or SPECT CT and 4D CT as well. At our institution, MRI and venous sampling aren't typically as commonly used because of its higher cost and also kind of more complex administration. And I will add, and perhaps Dr. Stack can also add to my comment as well, that at our institution, we started employing the use of an 18-fold choline PET CT. I don't know if any other of you have experience with that as well, but that's typically—
PET CT, you mean FDG PET or?
A 18F choline PET CT. So it's
okay.
In diagnosis of prostate cancer historically, has had some success in hyperparathyroidism for localization, and the studies have shown that that the choline tracer that's used compared to these technetium-99 has better spatial resolution and can actually report better detection for smaller adenomas, so those smaller than 200 milligrams. And so the sensitivities that have been reported are typically between 80 to 90%. And we just had actually, interestingly, a patient that underwent this exact scan was non-localizing on Cystomebi 4D CT and ultrasound CT, and was localizing on the choline scan. So,
okay, good. So,
and we
great.
operated on her, and we operated on her today.
Yes.
Okay, great.
Successful.
So a couple of questions from the audience. I think these are fantastic questions. Number one, for the group, do you guys use nerve monitoring when you do parathyroid? Let's just start with David. David?
I do.
Okay, Michael?
I do.
Brandon?
Absolutely.
Okay, anybody doesn't?
I don't, but I'm always rethinking about that possibility. I don't have a huge parathyroid practice, so.
Let me ask. So I used to do it because but then one of my residents convinced me that we don't need to do it. So recently I haven't, but I definitely don't blame anybody who does it, and maybe I'll go back. That's number two question, which is very interesting from audience, and I saw Mike already responded. I'm just going to read the question for you. Is any specific thing that surgeon can do other than obvious cure the patient of hyperparathyroidism to make endocrinologists very willing to refer patients to you? Well, I can tell you no. The answer is you can't do anything. They're gonna do what they're gonna do. But in general, don't cause complications and communicate and do the right thing. So that's it. But I'll let you at the end of the session. I have Brandon and others who are experienced with these to explain how they approach their endocrinologist colleagues. Tanya, who's the next case?
Next, we have Dr. Michael Singer, and presenting for him is Marwan. Is it Booley or Bullis? I'm sorry if I'm massacring the name.
Oh, no, you're good. It's Bolus, but.
Bullis, hi,
Yeah.
thanks.
Thank you. I'll share my screen here.
And I see we have Dr. Sherry-Ann Nathan. Sherry-Ann, if you at any point you would like to make a comment, please.
Always
Everyone
nice
see
to
my
have the
screen here?
president.
Yes.
Is everyone able to see my screen?
Yes.
Cool. My name is Marwan. Thanks everyone for having me. I'd like to thank Dr. Singer for letting me present this case. I'm a PGY3 at Henry Ford Hospital. Dr. Singer and I will be presenting a case on reoperative parathyroidectomy. So Dr. Singer got a patient referral, 73-year-old woman with a recently identified primary hyperparathyroidism. She had a history of nephrolithiasis, and she had previously underwent minimally invasive parathyroidectomy where one gland was removed, but she was not cured.
So when you say previously, like how long ago?
This patient had been operated on a year before.
Year before, okay.
So, Dr. Singer, what would be your initial considerations?
Yeah, so I think that if there would be like one theme to my approach to reoperative parathyroids is, and this is, by the way, even on my own patients, occasionally even I fail with my first operation, which is don't take anything for granted. So when I say that, what I mean is you really want to kind of start from the beginning with these patients. And so you want to reassess and confirm both diagnosis, but also then indications for surgery. Reoperative surgery has a lower risk of success and a higher risk of complications. So I think you really want to be careful that you're operating on patients who have the disease, but who really then are going to benefit from that operation. At the point that I've done that, the next step is to really start to just think about what disease we are dealing with and potentially what kind of went wrong in the first surgery, essentially what gland was missed. And when I say what kind of disease we're dealing with is assuming that the diagnosis is correct. There's a very big difference between a reoperative case where it's, say, for example, a missed single adenoma versus potentially a patient who has 4-gland hyperplasia where only maybe 2 of the glands were identified. Those are very, very different disease states, and for me at least, they have important differences in terms of the consideration for surgery.
So what is the battery of tests and imaging that you ordered for these reoperative patients?
Yeah, so basically I repeat the labs that we had kind of discussed earlier. And sometimes in these patients in particular, related to your question before, I really do oftentimes, if a patient has mild disease, I will do a 24-hour urine if they haven't had it done already. I've had a patient at least once, and I think actually a second one that I'm currently working up, who they had surgery and it was done, and I believe it was done because they have FHH and it just wasn't recognized. So I recheck all those labs, and then it becomes a question of imaging.
Okay, so let me ask the other, Brandon, what kind of labs do you order when you have a re-op?
Well, I think a re-op is very similar to doing a primary operation the right way. I do like Michael's point about the 24-hour urine calcium, because you might be catching the opportunity to prevent a second operation on FHH, which is never going to be cured by surgery. But basically, I'm using the same labs. We call it at our institution an 8-pack, but it's total calcium, ionized calcium, intact PTH, creatinine, magnesium, phosphorus, 25-hydroxy vitamin D, and chloride. I look at all of those, and together I'm able to help ascertain, is this a borderline case? Is this really just an anatomic technical problem with a straightforward primary case? Or are we looking at some odd situation?
All right, so let's ask Tanya. Tanya, what's your routine for reoperative cases?
I agree with all of that as far as blood work. I don't hesitate to repeat scans, absolutely. I do prefer to do a 4D CT because for me, it's more anatomic than the SPECT CT, and especially in a reoperative neck. I like to know ahead of time what I'm getting myself into. I think the biggest thing that I always, I'm a little OCD about is making sure that I get all previous operative reports and pathology. Sometimes somebody says they took out a parathyroid. It doesn't always mean they took it out until you correlate that with the pathology report. And then you kind of have to sit down and almost just write it out. Some people do that quadrant thing where they really sit down and figure out which glands were taken out, which glands were left behind. Previously, was it just a parathyroid biopsy or was it an actual excision of the gland? Because that really helps figure out what exactly is left remaining in the neck and where you need to target when you're going to be going back in.
Yeah, I think those are great points. So one thing I want to say, I don't know if the audience noticed, when we didn't have any localization, but it was obvious that it's parathyroid, everybody said, go ahead and operate. Here, you have that, but you have to have that extra step to make sure before you take the patient to the OR. Okay, Mike and Marwan.
I just want to say, and this goes to the point that Tanya just raised, is there is a paper that was put out by the endocrine section a couple of years ago. Actually, Brendan was the lead author on it, and it very nicely takes you through the reoperative cases and the kind of the quadrant approach that forensic analysis is described and shown in that paper. So if anyone is interested.
Okay, great. Yeah, if you just please send the link to that paper, that would be fantastic for the fellow.
One other
I see that Dr. Randolph is in the background not saying anything. So, Greg, if at any point you have any comments, please let us know.
Yeah. Can you hear me?
Yes.
Yeah, that paper is very good. I'm sorry, I was just in the OR late. That paper would be a very good way of defining that forensic analysis that Mike was talking about. It's a really important issue to not step into a hole.
Okay. All right, Marwan.
All right, moving forward. So, basically building off of that, we decided to confirm the diagnosis. So we did get labs. The serum calcium was 11.7. The ionized calcium was 1.54. Vitamin D was 43, and PTH was 212. And we also reassessed the indications for surgery, which again included a history of nephrolithiasis, and also taking a look at the labs included the degree of hypercalcemia. And also building even further in terms of the forensic analysis, we were able to get the path and operative reports. The pathology report revealed a 92 milligram parathyroid that was normal cellular. In terms of the operative report, what was documented was that a left inferior abnormal appearing gland was removed, but parathyroid hormone levels did not drop. Afterwards, a bilateral exploration was done where the right superior and inferior glands were deemed to be normal, and a left superior parathyroid was not identified.
So if they did bilateral, how is it this is minimally invasive?
Well, it depends on how you define minimally invasive. I have to say, in this specific patient, there wasn't much that I saw that was minimally invasive, at least as related to the scar or to the approach.
Got it. All right.
Although a lot of people will use that terminology when they do use a small scar. One comment I'd like to make is a 92 milligram parathyroid. Now, if that was the specimen that was taken out, and that's a parathyroid with some adjacent fat, And given that it was seen to be normal cellular under the microscope, that's likely a normal parathyroid. A normal parathyroid, when cleaned up of its fat, is going to weigh between 35 and 50 milligrams typically.
Yeah, so
that's a great point.
I agree. So there are a couple things I would just say quickly about this. I totally agree with Brendan with your comment. To me, that's just a normal parathyroid gland that was taken out. You'll see in the imaging next why I think that was done. But the other thing, and this goes to Tanya made this comment before, is I essentially don't trust anything except for the pathology report. So when they say that they saw the two glands on the contralateral side, that may or may not be true. And one thing, and this relates actually to the question before about endocrinologists and how you can kind of encourage them to refer to you. I think if you are in a situation like this, where you're in a surgery, you're struggling, maybe you found 3 glands, you haven't found the 4th or whatever else it is, I personally would highly recommend doing little biopsies of things that you think are parathyroid glands and marking those either with a clip or a stitch. And that basically sets you up, either you or someone else up for the next surgery. And I think it's a lot easier to explain that to a patient or a referring endocrinologist if it comes to that.
Mike, Mike Moore, do you get any other studies for the rehab?
Yeah, so Marwan, just go to the next case or the next slide. So this is the imaging, and everything about this looks like a left inferior gland. And this is similar to a case that I think Dave Shanka showed a couple of weeks ago. This is the most commonly missed single adenoma that leads to reoperative surgery. And this is what is going to be called a overly descended superior gland. So Marwan, can you maybe just go to, I got a CAT scan in this patient. She had had an ultrasound. I didn't see anything. I got a CAT scan. And Marwan, if you could maybe point out where this was.
Oh boy.
And this wasn't super low. It was clearly deep, as you could see. But what an overly descended superior gland really is it is a gland that has dropped lower in the neck. But it is still very deep. And depending on the sestamibi imaging, whether you get it just planar imaging or with SPECT, if you just get planar imaging, it can show up as brightness in that inferior area. And so when you go in, you'll go in and you'll find essentially a normal inferior parathyroid gland. Maybe you'll say, oh, I'm going to take it out, and the PTH level doesn't drop. And really, to find this kind of gland, you have to go deep, because the superior gland, regardless, is always deep or dorsal to that nerve.
So Mike, when you do an exploration on that side, what's your routine? What's your technique? Let's say you open the median raphe, push the muscles out, medialize the thyroid. Then what do you do? How do you make sure that you actually explore everything?
How I assure that
How you satisfy yourself that you explored the entire side? Like, what do you have any routine to go? I start from here, go this.
In a reoperative case, or in a primary case where I'm doing bilateral exploration?
Either one. You pick.
Yeah. So I mean, obviously, if I'm doing focus surgery, I always try and get broad exposure before I start to look for the adenoma, because I think that's one of the things that people do wrong is they're anxious to find the gland and they start looking before they're really ready to. So I always get broad exposure. But if I am doing, say, in a case like this, where I know I'm looking for a deep gland, one of the first things I'll do frequently is I'll find the nerve. The nerve is then going to dictate to me whether I need to be dorsal or ventral to it in terms of say, superior gland dorsal, inferior gland ventral. The other thing is that for reoperations, a lot of times what you'll find is that area is so extremely scarred. And so particularly for a deep gland like this, what I actually did was, instead of going kind of in the standard approach, I went between the strap muscles, came down onto the carotid sheath, where I actually found very little scar tissue, and then was able to find the posterior aspect of the thyroid. And once I did that and retracted sufficiently, the gland was kind of just sitting there almost up against the spine.
Babak,
Yeah.
can I make a quick comment about that?
Please.
2 comments.
We're actually going to spend most of the time talking about operative techniques and kind of pearls for fellows about how to do these tricky adenomas. So by all means, go ahead, Bernd.
So with this particular case, that it was reoperative, I would have gone through the pre-existing skin incision. I would have immediately taken a left turn and gone between the lateral strap and the SCM. I would have gone down to the carotid sheath and I would have looked a little medially, and I think I probably would have found this. I would have had the esophagus intubated with a temperature probe or whatever, so that I could palpate it and I could maintain my landmarks. But one question I wanted to go back to the SESTA maybe real quickly. I certainly would have gotten a 4D CT in this case, but for those folks that aren't inclined to do 4 CTs, or if we have any callers on that are from lower resource environment, the way you would have come to the same conclusion that Dr. Singer did with this 4D CT is, in addition to the AP view, if you'd taken a left and a right anterior oblique view, it would have looked like the parathyroid had moved, but we know the parathyroid doesn't move. That's called parallax, and that is the sine qua non for an overly descended superior parathyroid.
Fantastic. All right. I want to continue marijuana, and then we're going to have an open to comment discussion.
Sure. So in terms of our surgery, the reoperation, nerve monitoring was employed, an enlarged left superior gland was identified, and the postoperative labs can be seen below. So serum calcium of 8.7, an ionized calcium of 1.12, vitamin D of 54, and parathyroid hormone of 32.
Great. So I would say there are a couple of things that when I was listening to your excellent presentation. First of all, I have to say this is the first session that all presenters were residents. So congratulations, you guys did a fantastic job, and I hope this would be a precedent for other residents to be involved. And number two is, let's go back and look at the differences between these two. I think everybody would agree that we definitely need, if you do a re-op, use a nerve monitor. Would anybody go and in this day and age and not use the nerve monitor in a re-op? You could, but I don't think it's a good idea. Number two is what Tanya said about the imaging. And I would say something that, in thyroid surgery, they say you need to know your pathologist. In parathyroid surgery, you need to know your radiologist. Because if you don't, and if they don't have expertise, you don't have a good working relationship, you're not going to be helpful. My trick for identifying these deep glands is, I do a lot of spine. And if you notice, when you do a spine, you basically put your finger between the carotid and the laryngopharynx and go all the way down until you feel the spine. A lot of time you can do the same thing. Then you know that you are deep enough. And then if you go from lateral to medial, just feel it. A lot of times these are big adenomas and you can feel it, and that will give you the example. I really like the trick that you said, Mike, about going away from the scar tissue, and I think that's very helpful. So let's open for a few more comments. Let's start with David. David, what are your tricks for redo the thyroid?
No, I think well, number one, I don't try and do like a tiny incision if the previous surgeon has used a larger incision. I'll use small incisions when I'm doing directed or targeted parathyroidectomy on my own, but there's no sense in doing that if they've already made a decent sized scar. You want good exposure. You want to do safe surgery. I think finding normal structures in unscarred areas of the neck is really helpful because it just gives you landmarks to work with. So finding the nerve down low. I usually don't go lateral to the straps just because it's not a approach that I often take. And so I usually, just go through the midline as per usual and stay immediately deep to the strap muscles as I elevate them. although I can see, what Brendan says about staying in unoperated territory from the beginning, how that would be helpful, but I don't usually do that. And then I think the point that Michael made can't be emphasized enough about, knowing where the nerve is and then knowing how the parathyroids are going to sit relative to the nerve. And so the inferior glands are typically going to be, superficial to the nerve and medial, and then the superior gland lateral and deep. And so once you find the nerve, if you're looking for a deep parathyroid gland, even the overly descended deep ones, if you start your dissection lateral to the nerve, often you'll kind of encounter the vascular pedicle, and you'll actually be able to pull it up from superior. So basically the pedicle coming into the superior aspect of the gland, and you'll just kind of tease it out from deep to the nerve and off the prevertebral musculature from the top. And that I found that to be a really useful way of doing it. And usually, thankfully, the reason these haven't been identified is because the previous surgeon hasn't been there. And so most of the time, once you're actually around the parathyroid gland, it's pretty pristine territory.
Good. Tanya. Tanya, you're on mute.
Trying to unmute there. Sorry, yes.
Okay. And you had a question, so if you want to discuss it.
Sure. So just wanted to throw this out there, not specifically for reoperative surgery, but how many of the surgeons here, for someone that has localizing scans and you take out an adenoma, its characteristic appearance, your intraoperative PTH drops, how many of you will at least try to find that ipsilateral, sort of more normal parathyroid gland and document that? And then how many of you will go to the other side to explore the other parathyroids?
That's a good question. Let's see, Brandon, what would you do?
So before you even have the intraoperative PTH results back, you can easily see the ipsilateral normal parathyroid. Now, I do not routinely do bilateral explorations because I think there's a potential downside to that, especially in low volume surgeons. Even in higher volume surgeons, I have known that some of them have problems with hypoparathyroidism, at least transiently after doing routine bilateral explorations. So bottom line is I would try to identify a normal ipsilateral, remove the offending adenoma, wait for the intraoperative PTH, and then be done with it.
Mike, Singer.
Yeah, I mean, to me, it very much just comes down to if I'm doing, this goes to your comment before, Babak, of whether it's truly minimally invasive or if I'm doing a bilateral exploration. So I believe in the idea of focused surgery when appropriate, all right? There's no such thing as I always do bilateral or I always do focused. Every patient is different. But in a patient where I feel that focused surgery is kind of warranted and going to be beneficial for that patient, I take out what I think is the adenoma and I check PTH levels. Certainly, if it reveals itself the other normal gland on that side, I'll look at it. But otherwise, I do not routinely go and look for it.
And there's a question from Don asking, could you guys comment on when to consider parathyroid carcinoma on your pre-op workup? Who wants to take that?
I'll jump on it. The answer is when you have that, you'll know it. Those cases are not subtle. Those patients have come in with marked elevations in both parathyroid hormone typically, but certainly their calcium levels. Traditionally, as David said before, you're going to maybe feel something in the neck, but already when they come in and they have a calcium level of 15 or 16, you're going to immediately, I think, start thinking that way. And then the imaging oftentimes will also give you a sense that there is something different about that case.
I think something that's important, not only if you suspect it preoperatively, and I totally agree with what Michael said, is intraoperatively. Sometimes you get that feeling intraoperatively. And sometimes you'll reach out to your pathologist and they may or may not give you actionable information. So I think if you have a clinical suspicion that you're dealing with it's a hard, firm, some call it robin's egg blue type gland that's adherent. If you have a sufficient clinical suspicion intraoperatively, you should do an ipsilateral hemithyroidectomy and an ipsilateral level 6 dissection, because you want to try to remove everything and not have a reason to go back.
Great point.
Babak,
David, you had a comment?
I was just going to say it's worth, making sure that you're always prepared for that possibility, because occasionally something could come up. And so, I always tell my patients whenever I'm consenting them for parathyroid surgery that, on the consent form goes, even if it's a targeted lesion, parathyroidectomy, possible four-gland exploration, possible thyroid lobectomy, because you never know when you may find something that requires you to take out half the thyroid. You counsel the patients about the possibility of having to be on Synthroid after the surgery if you have to remove part of the thyroid. And occasionally you'll see that even with benign disease. I've taken out some parathyroid cysts that have been infected and they're so stuck to the thyroid that you can't safely remove them without removing the thyroid lobe, or parathyroids that are partially intrathyroidal that are near the nerve. And so you're worried that if you try and just, take it out of the thyroid, that you might spill it or something like that. So it's always worth being prepared.
Okay, Greg, please.
Yeah, Babak, I just wanted to thank everyone for participating, and also Tanya for all of her hard work and the work of all of the discussants and all of the great presenters, because they put this together with great speed and great efficiency, and it's all for you and the fellow program. So I really appreciate everybody's work, especially the leadership of Tanya. I just wanted to mention two things that I think are safety issues in terms of at least revision surgery. The first is you must have, and this is a point made in that document that I think Mike will send out, that for the Head and Neck Society, that you must have a target to utilize in revision surgery, or you don't reoperate. So a target on anatomic imaging is essential. And the second thing is, if you have a revision where they've taken out 3 glands and you're operating on the 4th gland, you need to be frank with the patient that if you have success in terms of hypoparathyroidism and take out that adenoma, that you may render them permanently hypopara. And you have to be very cautious and not rely on intraoperative PTH bottoming out, telling you whether you do or don't have any persistent non-adenomatous parathyroid tissue to make that decision, unfortunately. So there are just some words to the wise about some issues relating to safety. A targetable lesion, and be cautious that the gland that you successfully take out could conceivably be their only final gland.
Absolutely. Those are fantastic comments. And I would say parathyroid surgery is really one that you will benefit by talking to your colleagues. Endocrinologists, in case of foregone hyperplasia with your nephrologist, they can give you good input. And the one thing I would say, if it's your first year out of practice and you're doing a redo, it's a great idea to call your mentor and just kind of go through the check through the steps of the operation and the pre-op and everything. Just have a nice chat. It's so
and
much
any of us are available. Babak, any of the discussants, myself, Mike, any of us, Dave, Mike Singer, Brendan Stack, you all can contact the Head and Neck Society, get our email addresses. Any of us would be happy to discuss any case at any time.
Because if you don't do that, then you're in the OR and then you're going to start calling people and saying, hey, I have a problem here. It happens to all of us. Okay, great. Thank you so much. This was a fantastic session. I definitely learned quite a bit. I really appreciate Tanya and all the experts from the endocrine section, with my good friend Michael Singer, David Shanka, and Professor Brandon Stack, and also the fearless leader, Dr. Greg Randolph, and our own faculty, Dr. Michael Moore, Jeffrey Liu, I saw Rusha Patel. And if you didn't get to make any comments, please contact us. We would love to have you as presenters, as discussants. In 2 weeks, what are we doing in 2 weeks, Mike?
Let me look. I'll let you know here.
This is how informed I am. I don't know what I'm doing in 2 weeks.
Yeah, let's see. I got it. Where was our schedule? Here it is. Yeah, so it looks like on the 23rd, so 3 weeks, sinonasal neoplasms led by the skull base section.
Fantastic.
Bird
So,
and the skull-based team will be presenting in that one.
yeah, and I see that Ken is here. So yes, join us for another great conversation about the skull-based tumors. Thank you. Have a great night. I'll talk to you in 3 weeks.